Right. Hari. So nice to see all of you in one place again. Obviously, I can't see you, but that's fine. Fine. Let me just share this presentation first. Sorry. Sarang, you can see the screen, either?
Yes, sir, we can see.
Hi. Okay, fine. Right. Hi. So today is mostly intended as a test. There's only a few questions here which we will finish discussing, but it's sort of more like a test to see if you understand how these sessions will go, and then from next time onwards we'll obviously increase the number of questions that we do, because we need to do that before your exam. So how this works is, now at this time hopefully you should have started, or if you have not done, please start now revising the subject matter for your exam. So now is high time, if you have not already done so, to start studying for the theory exam. Okay. Now there are various ways in which you can do this. Historically, most people find it easier to study in a study group. So historically, people sort of form study groups and then discuss the MCQs and the SCQs in that study group. So I would say about 70 to 80% of the students generally prefer that method. So if you have not thought of doing this already, please start doing this from Monday onwards. But of course, this doesn't mean that everybody has to be in a study group. There are some people who prefer to study alone, and that is perfectly fine. Now, sometimes students call me and ask me, sir, apita study group pe karna hai, mokada karanne araka meka. It's not a problem at all. And some people prefer to do it alone, which is perfectly fine. For samahara ita study group pe athule karanakota, they feel that sometimes they're wasting their time or something like that. It's not a problem, as long as you can cover the areas properly. Now remember, it's not only medicine, there are lots of other subjects also, so you have to study everything. So make a timetable and plan and start studying. How these sessions are going to go is, I am going to give you the questions about a week beforehand. So Monday vitara, I will post the questions on the classroom, and then you have to answer the questions. Now, it is better if you can physically write some SCQ answers, and obviously I can't correct everything, but if you send, you can submit it, so I can have a look generally, right? Generally at a few of your answers and just give you some individual feedback. Now, last time we did this, 2013 lamai uttara liyala evwa. Of course, not everybody, about 50 or 60 people tamai oka karanne, but that is fine. I can glance through them. I won't be able to do a detailed review of them, but I'm happy to do that. So eka evanna then mandana මේක කවුරුත් එහෙම උත්තර ලියලා එවලා තිබ්බ බවක් මම දැක්කේ නැහැ ඊයේ නම්. So try to do that, because that's a useful thing to do. And we will answer. Also, Saranga, we have a group, the big group, batch group with me on it, WhatsApp.
Yes, sir, there's a WhatsApp group.
Yeah. So use that group to ask questions, MCQs that you have when you're doing the study group discussions or whatever. And I want that group being a bit busier, because but any question that you find it difficult to find the answer, please post it on the group. One, it is for your own education, and two, of course, other people also will know the answers to those questions, because every year there are certain questions that come up that people can't find the answer to. So that is the other way that you use these sessions, that you put questions on the group and I can answer them. Now, I have to re-emphasize that these are strictly confidential and you're not supposed to talk about this to anyone. And මෙහෙම කරනවා කියලා කියන්න එපා කාටවත්, right? Don't tell anybody and keep it amongst yourselves. As I've told you before, there are certain issues in this. It is not a problem for me to do MCQs because I'm on leave. Of course, if I was in the department and working, I would not be able to do it after a certain period of time. So close to your exam, it is prohibited to do MCQs, but because I'm on leave and I'm not involved in any of the paper construction making processes, I can do this. But even though legally I can do this, it is better to keep your mouth shut. හරි වැඩි කතා බහ කරන්න යන්න එපා මේක වදයක් වෙන්න පුළුවන් ඊට පස්සේ හරි so and the department also will do some MCQs I think somewhere down the line. Harsha has told me that some of the department will do MCQs ඒවටත් යන්න but this just keep confidential, don't even open your mouth to anybody that we are doing this හරි එක වාතයක් වෙනවා right, not even other departments or anybody කතා කරන්න එපා හරි right. So we thought we start off with cardiology. And so for the MCQ paper, I have made a presentation to go through. And also there is a accompanying note also, which you can use to study. Of course, I need to modify it a little bit, but I'll post the presentation and the note on the group for you to go through, right? So that's important. This note again is actually part of a book that we are at the moment finishing with Saroj and me and Harsha. So again, eka share karanne epa ogollo tiya ganna laga. Hari, don't give it to anybody else because it's going to be a sort of a textbook manual in medicine sort of thing, which is going to be published ultimately. Eka ogollo langa tiya ganna wena kaatawat denna yanna epa. Hari, so that is important. So all of this is strictly confidential. Keep it amongst yourselves. So today let's do this test session and see. And if you have any sort of ways that we can improve this, then we can adjust. So the main idea of today's session is to do a test run and see how things work. And from next week, we will do more questions. Sorry, make it but let's go. Fine. So heart failure. Right. Right. Now, today the sort of question session is going to be on chronic heart failure. Right? Chronic heart failure, and this is mostly theory and MCQs. For all of you, I have done a long case of heart failure. So we have done the clinical aspects of it. So here we have mostly the sort of theoretical aspects of it. Now, if you look for a definition of heart failure, so heart failure is actually a clinical syndrome. Right? It is a clinical syndrome where there is a set of symptoms and signs, right, which are associated with the heart not being able to function properly. So it's a collection of symptoms and signs which is due to problem in cardiac structure and especially in cardiac function. That is what it means, right? So that is what you mean by chronic heart failure. Right. Now, if we look at the first MCQ, now make it in a passe. So the first MCQ is focusing on heart failure etiology and pathophysiology. Right? So that's what the first MCQ is focusing on. Right. So, okay, right. Now, if you look at etiologies of heart failure, right, this classification is important, right? Now, as I will tell you later again, heart failure is classified into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Okay, so you have heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Okay. Now, very simply put, heart failure with reduced ejection fraction refers to a failure of systolic function of the heart. Okay, there is a failure of systolic function, ejecting blood out of the heart. So that is heart failure with reduced ejection fraction. So there is a problem with systolic function. Heart failure with preserved ejection fraction means that the heart is maintaining that ejection fraction. Okay, but there is a problem in cardiac filling. Okay, so there is a diastolic dysfunction. So there is a problem with cardiac filling and there is diastolic dysfunction. Okay, so very simply put, this is what these two mean, right? And if you have any questions, please ask or put them on the chat as we go. Right. So I have given you a list and you can see of causes classified based on whether there is reduced ejection fraction or whether there is preserved ejection fraction. Okay, right. So that is, just have a look at that. And if you notice, heart failure with preserved ejection fraction, mostly the problem is due to stiffness of the ventricle. That is the most common problem that we see, right? So stiffness of the ventricle means the ventricle cannot fill up properly. Okay, the ventricle is stiff and the ventricle cannot fill up properly. Okay, and when you try filling it, the pressure inside the ventricle rises, right? That is the problem. So you have a very stiff ventricle which cannot expand to fill up properly. And when you start filling it, the pressure inside rises. It's a stiff chamber. It is a stiff compartment. So that is what you mean by heart failure with preserved ejection fraction. Right. Okay. Now going back to this MCQ. So the first statement is ischemic heart disease accounts for most cases, right? And that is true for the moment. Okay, so if you take heart failure, most of the etiology is due to ischemic heart disease, right? And remember that very, very close behind is hypertension. Okay, so still, if you take the global statistics, ischemic heart disease accounts for most of the cases of heart failure, but hypertension is very closely second. Right? So that is, if you take etiology wise, these are the commonest two etiologies for heart failure worldwide. Right? Hari. So those are the two commonest. Of course, there are rarer causes also, as we might see as we go on in this MCQ. But at the moment, I would say that this is true. Okay. Now, the second statement in this MCQ is also very, very important to remember. Right? And all these are from your past papers and all of these things that you have collected, right, over a period of time. Read carefully, and this refers specifically to heart failure with preserved ejection fraction, right, is commoner in the elderly population. Now, this is again a true statement because of two things. As you get older, your ventricular muscle becomes stiff. Okay, as you get older, there is fibrosis of your ventricular tissue, and the ventricle becomes stiffer, right, as you get older. Another thing that happens is the incidence of hypertension increases as you get older, right? So the probability of you getting hypertension also increases as you get older. Right? So two things happen. So your ventricle becomes stiff with fibrosis, number one, and also the ventricle becomes thick because of hypertension, hypertrophy. Remember? So when there's hypertrophy, the ventricle becomes thick. Because of both of these reasons, the ventricle is very stiff. The fibrosis, and also when there's a lot of muscle also, the ventricle is very thick. So it cannot fill up properly, right? It cannot fill up properly. And there is diastolic dysfunction. Okay, there is diastolic dysfunction. So because of these two reasons, heart failure with preserved ejection fraction is commoner as you get older. Because the ventricle is stiff because of fibrosis, and because the hypertension goes up, the ventricle is hypertrophied as well. Again, it is more stiff. So that is the reason for that. Okay, that is a basis behind this statement. Okay. Right. Okay, and I think statement 4 also we have already answered during this discussion. So ventricular stiffness is a primary pathophysiological mechanism in patients with preserved ejection fraction. So that is the problem. So ventricular stiffness, diastolic dysfunction is the primary problem in patients with preserved ejection fraction. Okay. Right. Now, the third one, slightly difficult if you don't know what doxorubicin is. Okay. So doxorubicin is a chemotherapy drug. Okay. Now, another thing that we are seeing, now I told you that etiology wise, ischemic heart disease is the commonest cause of heart failure. Another thing that's happening now is that the incidence of cancer is going up in the population. Okay, incidence of cancer, and most of these chemotherapy drugs have cardiotoxicity, right? Most of these chemotherapy drugs have cardiotoxicity. So now what we are seeing is actually an increase in cardiac problems, especially heart failure in cancer patients, right? Heart failure in cancer patients. So this statement is true. Doxorubicin is a chemotherapy drug and can cause heart failure. And you need to remember also that the incidence of heart failure among cancer patients is also going up because of these various chemotherapy drugs, right? Chemotherapy drugs. So chemotherapy drugs are a common cause of, becoming a common cause of heart failure also because our cancer rates are also going up. So these are all epidemiology related, etiology related questions that you can get asked, or state things, points that you can get asked. Right. So fourth one is fine. Right, we've talked about that. And the last one is, let me read this off. So activation of renin-angiotensin aldosterone axis is, okay. So it counteracts the pathophysiological process. Now remember, the main problem, and you need to remember this very carefully, when you have heart failure, all of you know that as a compensation, right? You have heart failure, your tissue perfusion goes down. Tissue perfusion goes down. As a compensatory mechanism, you have activation of this renin, angiotensin, aldosterone system as a compensation. That is to sort of get the blood pressure up, salt and water retention, so that the tissue perfusion might increase. When the blood pressure is high, the tissue perfusion increases. When there is more volume, the tissue perfusion gets better. So your body is trying to compensate for the poor perfusion that occurs in heart failure by activating this renin, angiotensin, aldosterone axis. Right? But the problem here is, right? The problem here is, in the long run, the renin-angiotensin axis is harmful. Why? Because it causes high blood pressure, salt and water retention, right? Vasoconstriction, and a whole of other harmful things to the heart. So ultimately, the heart of the pathophysiology is the renin-angiotensin aldosterone mechanism. That is the heart of the problem, right? So initially what happens is the poor perfusion, you get increase of renin-angiotensin aldosterone, that have salt, water retention, the blood pressure goes up, vasoconstriction occurs, right? Try to compensate, but this is harmful to the heart. It increases the stress on the heart. And that actually promotes or worsens heart failure, right? So it doesn't counteract the primary pathophysiological process. It is the problem. It is the pathophysiological process that causes worsening heart failure, right? So all of you know this. Now, another little thing is that renin-angiotensin aldosterone system, counteract karana, there is another mechanism, right? Which is the BNP mechanism. Right? So this harmful renin-angiotensin aldosterone axis is counteracted by the BNP system, right? And the name BNP stands for brain natriuretic peptide. So natriuretic means there is more diuresis in these patients, right? So it counteracts this mechanism. Okay. So that is a little bit about the pathophysiology of what is exactly going on. So renin-angiotensin doesn't help in any way. It is the problem, right? It is the problem. Right. Any questions from this? So this is basically concepts of pathophysiology and etiology. Any questions? පළවෙනි MCQ එකේ එන පුනත් ප්‍රශ්න තියෙනවා. අහන්න දැන් මේක අය අහන්න වෙන්නේ නැහැ නේ. රිපීට් එකට තියාගන්න එපා. මේක පාරේ විභාගේ පාස් වෙන්න මේ කියලා දෙන්න. Right. Okay, fine. Let's move on then. So we're talking about the etiology and pathophysiology now.
So hypertension causes systolic dysfunction, right? There.
Both can cause both. So Systolic dysfunction in natural, but that's when you have very high blood pressure, because that can cause the ejection fraction to go down. But commonly what it causes is a stiffness of the ventricle and a diastolic dysfunction. Right? Dekama wenna puluwa.
Okay.
So Sanjay is asking, is diabetes an etiology of heart failure? So actually diabetes causes more of a ischemic sort of state in the heart, right? Because it causes coronary microvascular disease, right? So that is it's actually not a direct cause of heart failure. There is cardiac ischemia, which causes heart failure as a secondary phenomenon, okay? So diabetes causes coronary microvascular disease. Okay, so both good questions. Hypertension wala dekama wenna puluwan. Commonly what it is a left ventricular hypertrophy, ventricular stiffness, heart rate, preserved ejection fraction. But if the blood pressure is very, very high for a long period of time, it can cause the ejection fraction to go down because, of course, the resistance to the flow or after load deka වැඩි වෙන නිසා. Okay, fine. Right. Now, this is currently the diagnostic algorithm for heart failure. Currently, the diagnostic algorithm. So we talked about etiology now we are talking about diagnosis. This is currently the diagnostic algorithm. This is very, very new. This is end of 2021. If you are interested, the guideline is the European Society of Cardiology, which is the standard guideline for heart failure, right? Used in most countries, including Sri Lanka. There is another American one also, but it's slightly different. We mostly go by, our cardiologists mostly go by the ESC. Right. Now, remember that this diagnostic algorithm is not practical to do in Sri Lanka yet, because of a reason I'm going to tell you. But at the exam, make out to because you need to know the theory, right? So this is the theory. So how do you diagnose heart failure? Obviously, by a clinical picture. When I started off this discussion, I told you that heart failure was a clinical collection, or it's a syndrome of symptoms and signs. So you need to clinically suspect it first, right? And there might be risk factors. There will be symptoms, signs, which we have talked about in the long case, shortness of breath, orthopnea, PND, edema, symptoms, signs, cardiomegaly. We have already talked about that, right? So symptoms, signs. And they may have an abnormal ECG, right? Again, I have told you this in the clinical classes. One of the common things we see is the poor R wave progression, right? Poor R wave progression in the precordial leads. V1 to V6 or a poor R wave progression. So the first thing you do in the diagnosis of heart failure is you suspect it based on risk factors. Say they have ischemic heart disease, they are on chemotherapy, they have hypertension, whatever it is. Etiology, symptoms, signs, and an abnormal ECG. Okay, fine. Now, the second thing then you have to do after that is you measure something called the NT-proBNP or BNP. NT-proBNP is the proenzyme of BNP. Now, remember I was talking about this. This BNP system is a counteraction to the renin-angiotensin-aldosterone axis, right? So BNP does exactly the opposite of what the renin-angiotensin-aldosterone axis does. Okay, absolutely the opposite. So it causes diuresis, right? Excretion of salt and water. So that is what it does. So in heart failure, BNP levels go up. And currently, we use BNP for the diagnosis of heart failure, MCQ points, as well as for prognostication. So prognosis also, as you can see in this algorithm, it is used for the diagnosis. So the European Society of Cardiology recommends that once you have a suspected sort of heart failure patient, you do a BNP level, right? So BNP level. Okay, that is what you do. BNP or NT-proBNP. Right. So ඒක MCQ වලට අහන්න පුළුවන්. හරි? Namuth the problem is in Sri Lanka, we don't have access to this test. It is expensive, currently done only in the private sector. Right? If I'm wrong, just tell me because I haven't practiced for 2 years there. Is it done in the NHSL? I don't think so. Karanawada NHSL. Okay, so Hansi says it is available now, which is useful information. Good. So that is interesting. So yes. So if you have the facilities to do NT Pro BNP or BNP, we can do this test. Okay, we can do this test. And that will be high in heart failure. So remember the point, guys, it is a diagnostic marker as well as it is a prognostic marker as well, right? Prognostic. So the more severe the heart failure, the BNP level will be higher. Okay, good. But if you don't have BNP, you can directly go to echo. Ne? Directly go to echo yannat puluwang, right? So ema karannat puluwang, but you do this and then echo, right? And then using the echo, you have to differentiate or classify heart failure then into, now we classify it into 3. But now they have introduced a mother category also. So let me go through these 3 things now. So heart failure with reduced ejection fraction is when your ejection fraction is less than 40% on echo. So you do everything, echo ekin tama ituru tika yanne. So this is less than 40. If it's more than 50, that is heart failure with preserved ejection fraction, more than 50. Anything in between, so 41 to 49%, is called heart failure with mid-range or mildly reduced ejection fraction. Madak tiyanawai. A madak tiyanne ai kiyala ogolo magen ahuwot, there is a sort of clinical trial reason for that to exist. ඒක ගැන වැඩි කලබල වෙන්න එපා. ඇයි මේක තියෙන්නේ කියලා. Some drugs, even though they don't work for preserved ejection fraction, they work for this mother thing. So that's why there is such a category now. Right. And then once you classify it, you do the echo, you classify it into one of these groups, and then you talk about etiology and start treatment. So this is a very important algorithm for you to know theoretically. Diagnosis of heart failure. So first, clinical risk factors, symptoms, signs, ECG, right? Then you diagnostic, prognostic marker. The echocardiogram into reduced ejection fraction, preserved ejection fraction, but there is now a new middle category also that is described. Once you do this, now you can go ahead and treat. Right? So this is the diagnostic algorithm. Any questions from this? Okay. So now,
sir, is echo helpful in differentiating those reduced ejection fraction and preserved ejection fraction? No, just important in diagnosis also.
So echo is mostly now used to differentiate between these sort of, to classify it. It is a diagnostic marker also, diagnosis tamai. But it is also used to classify based on ejection fraction. So both, the diagnosis and classification, both echo is very useful. But now, so when we were talking about heart failure a few years ago, this BNP story was not there. Now it is a simple marker that you can test for heart failure. When you are not sure. So for example, a classical example is sometimes you have the problem, is this asthma, is this heart failure, shortness of breath, a patient, make a respiratory, the heart failure, those sort of things, BNP is very useful, right? Very useful. Now, you also have to recognize that BNP is not only elevated in heart failure, it's elevated in other things also, right? But this become a very useful biomarker for heart failure now, right? So that is something relatively new. Lectures are going to kira dunnada, I have no idea. But remember, medicine changes. So things are changing, especially heart failure, things are changing quite a lot. Okay, fine. Right. Now, we've talked about the etiology and the diagnosis now. So let's talk a little bit more about those in an MCQ also. And these are certain aspects that you might get. Right. So heart failure can lead to hepatic dysfunction. That is the first statement. So now this diagram here, and I think next time I'll give you this presentation before the class, because you can write on it or do whatever you like. So when you're describing the symptoms of heart failure and the signs of heart failure, it is useful to classify heart failure into right heart failure and left heart failure. So this is purely when you're sort of understanding the symptoms and signs, right? It is useful to think of right heart failure, left heart failure. So when there is, because of right heart failure, what happens is there is congestion of the right-sided circulation, right? Right-sided circulation. There is congestion, right heart failure. The heart is not pumping out properly or is filling up with abnormally high pressures. So there is problem in the congestion in the right-sided circulation. And as you know, the right-sided circulation brings blood from the SVC and the IVC, SVC and the IVC. So therefore, you get dependent edema, hepatic congestion, very common. Hepatic congestion is very common because that is coming right into the right heart. From the liver, blood is coming from the gastrointestinal tract. So because of the right heart congestion, right circulation congestion, they get edema, ascites, gut edema, right? Hepatic congestion, right? That is due to right heart dysfunction. Right heart dysfunction. When there is left heart dysfunction, the congestion occurs in the left circulation. It can in circulation. Left comes from the pulmonary veins, from the lungs, right? So now the lungs are congested, and that causes pulmonary edema. Right? And that's why you get orthopnea, exertional dyspnea, paroxysmal nocturnal dyspnea. So that is because of pulmonary edema. So you can understand a lot of the clinical symptoms by classifying or understanding it as a right heart failure, left heart failure. Now, when you manage the patient also, this can be useful sometimes, but this is mostly to understand the symptoms. Because as we have just discussed, the main classification is based on the ejection fraction, right? So that is the standard classification. But thinking of heart failure as right and left heart failure is useful to understand signs and symptoms. Okay. So right heart failure causes liver congestion, gut edema, and ascites edema, whereas left heart failure causes congestion of the lungs and pulmonary edema. So that is already, you know this, right? So going back to this MCQ then, right? So heart failure can lead to hepatic dysfunction, yes, because of the hepatic congestion. And sometimes it can lead to cirrhosis of the liver also, right? It can lead to cirrhosis of the liver also, right? And that's called cardiac cirrhosis, right? Cardiac cirrhosis. Right. Okay. Now, what is pulsus paradoxus? What is pulsus paradoxus? Now, if you take symptoms of left heart failure, symptoms, orthopnea, PND, exertional dyspnea because of congestion in the lungs. The other physical signs are, especially when there is left heart failure, is this. Okay. So, uda tiyenne pulsus alternans කියන එක. You can see graphically what it means. So change in the arterial pressure. You can feel it in the pulse also. The pulse changes beat to beat. Pulse volume, blood pressure changes beat to beat, as you can see here. Uda. Pulsus paradoxus is something completely different. Right? ඒක අපි කතා කරනවා in more detail when we do pericardial disease probably next week as an MCQ topic, right? So that is different, right? So pulsus alternans කියන්නේ variation of pulse volume from beat to beat, as you can see here. So actually in left ventricular failure, pulsus paradoxus නෙවෙයි එන්නේ, pulsus alternans is what you get. So pulsus paradoxus is most often seen in lots of pericardial disease. And I'll explain that a little bit more when we do pericardial disease, because there's some other signs I need to explain with this physical sign. So pulsus paradoxus, pulsus alternans is actually a very good diagnostic feature of advanced left ventricular failure. So when a patient is almost at the end stages of left ventricular failure, they get pulsus alternans, pulsus alternans. So again, look at this figure, which looks at a graphical representation of what pulsus alternans is. So variation of pulse volume from beat to beat is what happens in pulsus alternans. Right. Okay. Right. Now, there are 3 MCQs based on investigations here. In this 3-4-5. So we have already answered the 4th MCQ. NT-proBNP has a prognostic value. It also has a diagnostic value. I told you this. So that is true. Make it true. Now, MCQ number 3 looks at investigation findings on the chest X-ray. And this picture shows you all the findings. Right. So chest X-ray, ignore the pacemaker, that's useless. So if you, this is very important even for a clinical case discussion, long case discussion or ski, everything is important, right? And you can see the key X-ray signs of heart failure in this. Cardiomegaly, pleural effusions, pleural effusions. Then there is prominence of the hilum bilateral hilar prominence. And that is again because of the pulmonary edema, bilateral hilar prominence. And then you can see upper lobe diversion, upper lobe diversion. Also these short horizontal lines that you can see are called curly B lines. Curly A lines but in heart failure what you get is curly B lines. So this is sort of horizontal, very short lines that you can see. Curly B lines. Curly B lines. Okay. So these are the X-ray changes of heart failure, right? Cardiomegaly, pleural effusions, hilar prominence, upper lobe diversion, and curly B lines. So these are what you see. This is very important. Okay. So curly B lines are seen on the chest X-ray is true then, right? That is something that you see. Now the next one, elevated troponin invariably indicates myocardial ischemia. Now sometimes English can be a bit difficult, I know. It's quite unfair, but there we don't have a choice. We have to give a paper in English. So invariably can always, invariably, right? So remember, this is false. If you measure the troponin in heart failure, it will be high, right? It doesn't mean that there is a MI going on. It essentially means the heart is under stress. So when the heart is under stress, it leaks troponin, right? It leaks troponin. And that is not a feature that you can't diagnose an MI just because the troponin is high. So how do you diagnose if somebody with a heart failure gets a MI? That is where the serial measurement of troponin comes in. So in heart failure, they will have a little bit of troponin elevation because the stress on the heart, there is leaking of troponin into the blood. But if there is MI, if you measure 2 time points, say time point 0, troponin is about 20, time point packing with troponin is about 20,000. So there you know that definitely there is some acute coronary ischemia, right? So that is how you diagnose MI in heart failure patients. But remember, troponin එක වැඩි වෙච්ච පළියට MI කියලා කියන්න බෑ. Troponin is elevated in heart failure because of the stress on the heart. So investigation wise, these are the things that you need to know, right? Also remember, MCQ hyponatremia is also quite common in the investigations in a heart failure patient. The reason is because of the fluid overload, right? Because of the fluid overload, there is dilutional hyponatremia that occurs. Right? because of fluid overload. Okay, Hari. Another thing that's very common is hypoalbuminemia in heart failure, especially advanced heart failure. You get low albumin. MCQ වලට අහලා තියෙනවා. Low albumin. Low albumin. Investigation නෙමෙයි කියන්නේ ඒකයි. Low albumin is mainly because I told you that when there is right heart failure, there is GI tract congestion, right? GI tract congestion. And because of the GI tract congestion, they get protein malabsorption, right? Protein malabsorption, GI tract congestion. So hypoalbuminemia is also quite common, right? Hypoalbuminemia. The other thing is elevated transaminases because of hepatic congestion. So these are some of the investigation findings. So low sodium, hepatic congestion causing elevated transaminases, low albumin, right? These things we often see in heart failure patients. These are investigation findings. Right. Okay. Good. So BNP we have talked about. So this just gives you an idea of how BNP works. So pro-BNP is the pre sort of metabolite, and then this active BNP counteracts the renin-angiotensin mechanism. So it uses a diagnostic and a prognostic marker. Right. Okay, right. Right. Any questions? Right. Right. Now, when it comes to management of heart failure, okay, again, things have changed. Right? Now, in your clinical classes, I would have told you about 4 stages of heart failure, which are very useful in the management. So stage A is, stage A is the patient has risk factors for heart failure, but their hearts are structurally normal and they don't have any symptoms. Stage A. Right? Stage A. Okay. Stage B is where they have structural heart problems. Say they have an MI in the past. The structure of the heart is abnormal, but they don't have any symptoms or signs of heart failure. Right? Symptoms or signs of heart failure. Right. Stage C කියන්නේ, right? Stage C කියන්නේ, they have structural heart disease and symptoms and signs. ඔක්කොම තියෙනවා. Structural heart disease and symptoms and signs. Stage D is sort of a more advanced state of stage C, where the sort of disease is refractory, right? So you've given your medication, but still things are not working properly. Right? So A is they have high risk, but no changes, no symptoms. Stage B is they have structural problems, but no symptoms. Stage C is what you know, that is, they have symptoms and signs, right? And then stage D is more of a refractory stage of heart failure. Right. Okay, fine. Okay. Now, when you manage heart failure, okay, when you manage heart failure, it's very clear that the heart failure management of reduced ejection fraction is very, very clear. There is no doubt about it. Established management. Right? Established management. Reduced ejection fraction. Right? Preserved ejection fraction, we are not very sure of how to manage. Right? The evidence is not strong there. Right? But reduced ejection fraction is clear, very clear. Okay, so that's the first thing you need to remember. Now, this is again very new, very new. The European Society of Cardiology now tells us, right, as of last year, end of last year, that they would recommend 5 drugs as first-line therapy. 5 drugs as first line therapy. 5 drugs. Okay. 5 drugs. 5, there are 6, but you have a choice at the first one. ACE inhibitors, definitely yes, no doubt about it. That is a first line drug. So remember, this is all heart failure with reduced ejection fraction. ACE inhibitors, definitely yes, no doubt about it. Right? Beta blockers, definitely yes, we use these in Sri Lanka, no problem there also. MRA කියane ළමයි mineralocorticoid receptor antagonists, and what we use in Sri Lanka is spironolactone. So it is very clear now that first line therapy is ACE inhibitor, beta blocker, spironolactone. Edavaswala spironolactone, or maybe 6 months ago, spironolactone was second line. Now they have taken it up to first line, right? So ACE inhibitor, beta blocker, MRA, no problem. You can use those. Those are first line drugs. Right? As well as diuretics. You have to give a diuretic in patients with heart failure, absolutely. Right? You have to absolutely give a diuretic. No kata. Yeah, you have to absolutely give a diuretic. Now, there are 2 new drugs on this list, which one of them is not available in Sri Lanka at all. The other, or maybe in the private sector, but one now we are using for diabetes, right? Made dapagliflozin, empagliflozin can SGLT2 inhibitors. Remember when we are doing the clinical diabetes classes, we talked about this, SGLT2 inhibitors. And now we know very clearly from lots of trials that these drugs are effective in heart failure also, even in non-diabetic people, right? So now the world is going towards a thing where SGLT2 inhibitors are very good in heart failure, reduced ejection fraction, and are recommended to use in some countries in non-diabetic people also for heart failure. So a dapagliflozin, empagliflozin can SGLT2 inhibitors, which are now recommended as first-line therapy for heart failure, even in non-diabetic people, right? Right? There are some, I think I might have talked about this for some groups at least, because it's very new, right? Antima group, kaling group, first few groups, I'm not sure because it's a relatively new thing now, right? So SGLT2 inhibitors now have come right up into the top for heart failure, reduced ejection fraction. ආනි කියන්නේ මෙතන උඩ තව එකක් තියෙන්නේ ආනි කියලා ARNI, that's angiotensin receptor blocker neprilysin inhibitor combination. Now angiotensin receptor blocker, you know, right? ඔය මේ losartan group එකේ drugs. Neprilysin inhibitor is a drug that raises BNP levels. So neprilysin is the enzyme that breaks down BNP, right? It breaks down BNP. So by inhibiting neprilysin, BNP levels will go up. BNP levels very well, right? And that causes diuresis, salt and water excretion. So that is, this drug has a mechanism. Angiotensin receptor blocking, it blocks the angiotensin mechanism, which is harmful. By increasing BNP, promotes salt and water excretion, diuresis. So that is another drug which you can use instead of an ACE inhibitor, angiotensin receptor blocker plus neprilysin inhibitor. So neprilysin කියන්නේ මොකද්ද? It inhibits, so neprilysin breaks down BNP. So when you inhibit neprilysin කියන enzyme එක, it increases the levels of BNP. So these are the 5, ne? And now people are saying me pahama පටන් ගත්තත් කමක් නැහැ මුලින්ම, but that's a bit too much for you. ලංකාවේ අපි කරන්නේ ACE inhibitor, beta blocker, spironolactone should be started. But then there are 2 new drugs and loop diuretics like furosemide. But the other 2 drugs also can be considered, especially SGLT2 inhibitors. ACE inhibitor එක ආනි එක එකට දෙන්න බෑ. එකට දෙන්න බෑ. ඒක හරි, එකට දෙන්න බෑ. Okay, so those are the first line drugs කවුරු ඇහුවොත් ඔය පහම 6ම කියන්න පුළුවන්. Right. Okay. Now going back to the MCQ. Furosemide has extensive evidence-based survival benefit. Eka harida? Now, here I told you there's a problem here. The long case make a furosemide probably has a survival benefit. There's no doubt about it. But evidence-based why? What is the reason? There are no clinical trials that you can do where you can stop furosemide in a patient with heart failure and give them a placebo because it's unethical. Patient අනිවාර්යෙන් මැරෙනවා furosemide දුන්නේ නැත්නම් මැරෙනවා. I think Professor Constantine would have also told you this point. Furosemide has a survival benefit, but you can't prove it, right? So extensive evidence-based එකක් නෑ ඒකට. ඒකයි ප්‍රශ්නේ. But your common sense tells you furosemide දුන්නේ නැත්නම් ලෙඩා මැරෙනවා කියලා. So that is a tricky MCQ. There are at least no good clinical trials that shows you that furosemide has a survival. But it has, but you can't test it because it is unethical to stop furosemide to a group of people, right? But lamai, there are lots of clinical trials for ACE inhibitors, survival benefit එකක් තියෙනවා. ANI වලට survival benefit එකක් තියෙනවා. Actually, more than ACE inhibitors, ANI have a better survival benefit, but it's expensive. Beta blockers have a survival benefit, but remember it is only a few beta blockers. Monothers beta blockers carvedilol, bisoprolol, metoprolol. Spironolactone has a survival benefit. SGLT2 inhibitors have a survival benefit. So all of these drugs have a survival benefit in heart failure, right? So there is no doubt about that. So now, angiotensin receptor blocker candesartan is a first-line drug, never. So look at this table carefully, right? Look at this table carefully, this flow chart. Metan 82 inhibitors ne, right? So it's ACE inhibitor or ANI here. That's first line. So angiotensin 2 receptor blockers have gone out of the first line level. So they are no longer considered first line drugs. So it's either ACE inhibitor or ANI. One of the two. ACE inhibitors have a role in management of asymptomatic heart failure. Now, that is also true. Now, when you have heart failure early stage, right? We make a product outdated. So, if you have early stages, for example, you have structural heart problems. So, stage B bagi. So, there is structural heart disease, but no symptoms, signs of heart failure. In those sort of people, also ACE inhibitors can be used and they have a prognostic benefit. So, not only in people who have symptom signs, even in the stages before they develop symptom signs, asymptomatic, but they have structural heart disease, ACE inhibitors still have a prognostic benefit, mortality benefit. Okay, fine. Spironolactone does not have an effect on mortality. Boru katawak eka, right? So that is false. It definitely has an effect on mortality. There is no doubt about it. Right. Okay. Now, this last drug, ivabradine, right, is a drug that slows the heart down. The main mechanism, it slows the heart down, right? It blocks the sodium channel in the SA node. That is a second line drug. Say when you have a patient on beta blockers, optimum dose, and you want to slow the heart down a little bit to reduce the strain on the heart, you can use ivabradine on top of beta blockers. Right? Ivabradine on top of beta blockers. Remember, always on top of beta blockers. And this is a point, atrial fibrillation is contraindicated. It actually worsens atrial fibrillation. So this MCQ statement is false. Ivabradine it can be added on to beta blockers and it has a mortality benefit when added on to beta blockers. It's a MCQ point, right? And it's contraindicated in AF. මේ MCQ මම දැම්මේ ඔයගොල්ලෝ ඉවබ්‍රැඩින් ගැන වැඩි අහලා නැති නිසා ඒක පොඩ්ඩක් ඒක දැනගන්න. It is a second line drug for heart failure added on to beta blockers. හරි ළමයි. තව පොඩි කාරණයක් තියෙනවා මෙතන. ඒ තමයි මේක. There are other second line drugs. ලංකාවේ පාවිච්චි කරන ඔය අහන එකක් තමයි digoxin. Digoxin does not have a mortality benefit. Remember, digoxin does not have a mortality benefit. Right? Digoxin does not have a mortality benefit. Hari. Right. So we will come to this. Just give me a minute. මෙතන ප්‍රශ්න වගේක් තියෙනවා අපි ඒ ටික බලලා ඉමු. So Senor is asking, sir, can cardiac cirrhosis also be considered a cause of hypoalbuminemia? Yes, that's correct. Okay. How do serial, so you can say, so hypoalbuminemia due to gut edema, protein malabsorption, plus cardiac cirrhosis also can be taken as a cause. Yes, that's right. How do serial troponins change other things like myocarditis, sepsis? So it's all, in sepsis also the troponins can go up. Myocarditis also the troponins can go up. Myocarditis, it can go up a lot, and you have to be very careful in that sense in diagnosing acute coronary syndrome. Sepsis it can go up a little bit. So all this sort of percentage rise that you're looking for, right? Sepsis pathophysiology of curly B lines, don't worry. Essentially, curly B lines are fluids in this small fissures fluids in lung, right? Curly B lines can. Now here is a best response MCQ that also sort of looks at treatment, right? 50-year-old developed shortness of breath, leg swelling while away on a business trip. He was told that he had congestive cardiac failure, asymptomatic now. So he had symptoms before, but asymptomatic now. Symptoms koi kale hari tibunath symptoms තියනවා කියලා ගන්න. Echocardiogram shows an ejection fraction of 38%. Aspirin simvastatin දෙනවා. Now, so it's essentially asking first line drugs for heart failure නේ අහන්නේ නේද? So මොනවද මේකේ පටන් ගන්න ඕනේ? So මේකේ perfect උත්තරේ නෑ, but essentially ACE inhibitor beta blocker අනිවාර්යෙන් පටන් ගන්න ඕනේ. There's no doubt about that. But the first line drugs you have to start. So ACE inhibitor, beta blocker, spironolactone පටන් ගන්න ඕනේ. ඇත්තටම තුනම පටන් ගන්න ඕනේ කියලා තමයි කියන්නේ. Yeah, so that's it. Furosemide again, when there are symptoms, the patient needs to be on furosemide. So there is no good answer in this. The best answer, the perfect answer kannaya meke, because this is a rather old MCQ. Then තියෙන විදිහට ළමයි heart failure with reduced ejection fraction. So less than 40 නේ මෙතන. එතකොට less than 40 නිසා you have to start the patient on some first line medication. This the best answer is number 1 because may list taking make a ACE inhibitor, beta blocker, ideally also this spironolactone පටන් ගන්න ඕනේ ideally. ඒ දවස්වල spironolactone නිකන් second line එකක තිබුණේ, but now it is considered to be first line, right? So that is important to remember. පොඩි වෙනසක් එක. හරි? ඒක වෙනසක්. And loop diuretic for symptoms, fluid retention, right? Okay. Hari, any questions up to now?
Totally. If we start furosemide and if the symptoms like improve with furosemide, are we going to stop in the long run?
You can reduce the dose and sometimes stop, but practically ගොඩක් වෙලාට අමාරුයි හැම වෙන්නේ නැහැ. But you can try to reduce the doses and stop it if the patient is asymptomatic.
And in this the stage 1 also, all these 5 drugs are indicated in the heart failure.
So that's what they say now, Sachit. So they say ඔය හැම එකම පොඩි small doses වලින් දෙන්න කියලා. But in Sri Lanka, we don't practice that yet. So in the UK, for example, or in Europe, what they're doing is they are giving all 5 small doses of all 5. තේරුණාද? එහෙම කරන වෙලාවල් තියෙනවා. But in Sri Lanka, I would say most of the time we would start beta blocker, ACE inhibitor, and maybe spironolactone first. We still don't use this SGLT2 inhibitor for heart failure as far as I know. ලංකාවේ ඔක දැන් ළඟදීම පටන් ගන්න පුළුවන් because it's recommended now to use. In diabetics, yes, but in non-diabetics, some countries have said yes, some countries are still studying whether that is useful කියලා. but that's all what the sort of evidence shows. Hari. So Umaya, Candesartan and Valsartan both are ARBs. Aniyeke Umaya make a tekka. ARB ka tekka, there is another drug. So Valsartan is not an ANI. Valsartan is also an ARB, but ANIyeke ekai thawa ekakuයි තියෙනවා. So there is Valsartan plus a neprilysin inhibitor. ඒකට කියන්නේ sacubitril කියලා. So ANIyeke තියෙන්නේ Valsartan and sacubitril. Right? So sacubitril is the neprilysin inhibitor which increases the BNP level. Right? Now we know that ARB alone there is not much benefit here. Right? So it's either S inhibitor or ANI. Lankawe ANI denna bෑ දැන් because it's very expensive. Right? Right. Okay. Now beyond the first line, what do? So if you give first line medication, patient is not responding, right? Then we use device therapy. Device therapy. Right? Device therapy. Okay. So device therapy is indicated when you give the first line, but patient is still symptomatic. මම මේවා කියලා දීලා ඇති device therapy කියන්නේ CRT කියන එක මම ඔයගොල්ලෝ long case වල කියලා දීලා තියෙනවා. CRT. Cardiac resynchronization therapy. හැබැයි මෙන්න මේක පොඩ්ඩක් මතක තියාගන්න මේක සමහරවිට MCQ වලට අහනවා. To put a CRT there are 3 requirements. 4 requirements to put a CRT. 1, they should be on first line medication. ඒක නැතුව CRT දාන්නේ නැහැ. First line medication දෙන්න ඕනේ. හරි. To put a CRT they should be in sinus rhythm. SR කියන්නේ sinus rhythm. Ejection fraction should be less than or equal to 35%. And in the ECG, right, in the ECG, the QRS duration, QRS length should be more than 130 milliseconds. 130 milliseconds. Right? 130 milliseconds. Especially if it's more than 150 milliseconds, very strong evidence. Very strong evidence if the QRS is more than 150. ඔගොල්ලෝ මේ පොඩ්ඩක් class 1 class 2 කියන evidence categories ඒවා ගැන වැඩි දැනගන්න ඕනේ නැහැ. But if it's more than 150, very strong evidence. But even above 130 there is evidence. So CRT device කියන්නේ cardiac resynchronization therapy that is used. You're on first line medication, you have to be in sinus rhythm, ejection fraction should be less than 35 and the QRS duration in the ECG should be more than or equal to 130 milliseconds. So that is when you do a CRT device. CRT device. That is after you try your medical management. මං හිතන්නේ මේ ඊගාව MCQ එකේ ඔක තමයි අහන්නේ. හරි. So 65-year-old man symptomatic bisoprolol, ramipril, furosemide, spironolactone ඔක්කොම මගුල් ටික දෙනවා, but the patient is still symptomatic. Attempts to increase the doses of these drugs have been prevented by hypotension. Echocardiogram confirms severe left ventricular impairment with ejection fraction of 30% and sinus rhythm, long QRS more than 240 milliseconds and a left bundle branch block. Sorry. එතකොට බලන්න patient is on medical management. Neither this patient is on good medical management. දැන් මේ ප්‍රශ්නේ හදන කාලේ SGLT2 inhibitor තිබුණේ නැහැ. නිසා ඒක ගැන වැඩි හිතන්න එපා. හරි. Then patient is in sinus rhythm. Patient has an ejection fraction of 30%. Patient has a QRS of 240, which is much more than 150 also. So here the next best treatment is to go for a cardiac resynchronization therapy. Cardiac resynchronization therapy. Hurry, that is the best to go for. Hurry. Right. Okay. Any questions from these? Just give me a minute. Hurry. Any questions from these things that we've discussed, the management? So this is all Ramai, heart failure with reduced ejection fraction. Right. Any questions? So you have to know this table නේද මෙන්න මේක දැනගන්න ඕනේ මෙන්න මේක දැනගන්න ඕනේ හරි very important මේ ඉතුරු ඒවා ගැන වැඩි කලබල වෙන්න එපා ඔය heart failure සමහරට ICD දානවා implantable cardioverter defibrillator don't worry about that that's a bit postgraduate right so don't worry about that too much but CRT ගැන චුට්ටක් දැනගන්න ඕනේ ඒ නිසා තමයි මම මේක විතරක් කිව්වේ ඒකයි so Pratibha CRT is not actually biventricular pacing as there are 3 leads right so there are 3 leads in CRT okay so it's actually a biventricular plus there is another lead somewhere else also okay inotropes Chandu is mostly inpatient okay inotropes are inpatient so you can't give them as outpatient medication right so eva inpatient medication vitarai so stage D you try device therapy that is the more effective option of the lot okay so a few more on the management digoxin therapy මේ පළවෙනි statement එක එහෙම මතක තියාගන්න digoxin is a second line drug it doesn't have mortality benefit but improves the quality of life and reduces hospital admissions when added on to existing therapy හරි ඒක තමයි ඒක එහෙම මතක තියාගන්න ඒක තමයි ඒකේ හරි use එක right digoxin beta blockers are contraindicated in patients who have a history of COPD so this beta blocker කියන්නේ referring to heart failure beta blockers which are cardioselective so these are not contraindicated in COPD but you have to be careful so caution right even in asthma you can use but obviously we don't push it that far COPD will caution because they are cardioselective they don't act a lot on the respiratory system but they should be used with caution right තුන්වෙනි එක පල්බොරු routine anticoagulation with warfarin is never indicated in heart failure because that is not at all correct right එහෙම එකක් කරන්නෙම නැහැ unless of course there is you see a clot in the heart right you see a clot in the heart yes anticoagulate අර intraventricular clot එකක් තිබුණොත් විතරයි you anticoagulate right otherwise definitely not there is no indication at all right routine so the only 2 instances where you might use anticoagulation in heart failure are number 1 if there is an intraventricular clot right number 2 if there is AF right AF තියනවනම් anticoagulate කරන්න එපා because of the AF right but otherwise no routine anticoagulation that is very clear right no routine anticoagulation right. so why do so අන්තිම එකත් හරිය CRT ICD කියන එක කපා ගන්න එතන මම වැරදිලා that is දෙකම හරි CRT විතර කරන ICD ගැන ඔයගොල්ලන්ට වැඩි උගන්වන්න නැහැ CRT yes mortality benefit එකක් තියෙනවා right that yes definitely yes why do heart failure patients die mainly because of ventricular arrhythmias right that is the most common cause of sudden death in patients with heart failure ventricular arrhythmias so ඒකයි ඔය ICD කතාවක් ඉන්නේ ICD කියන්නේ මොකක්ද කියලා ඔයගොල්ලෝ දන්නවනේ implantable cardioverter defibrillator so ICDs are used for patients who have ventricular arrhythmias mostly so ඒක දැම්ම ගමන් ඉබේටම shock වෙලා නතර වෙනවා ventricular arrhythmia එක right so this flow chart is very important please remember this indication for CRT එක මතක තියාගන්න first line drugs මොනවද කියලා මතක තියාගන්න right hari so alpha blockers වැඩක් නැහැ for heart failure with fluid overload there is no use for alpha blockers no hari okay right now so there is heart failure now a little word about heart failure with preserved ejection fraction එකේ ළමයි වැඩේ තියෙන්නේ මේකයි there is not much evidence the only positive clinical trial only positive mortality benefit clinical trial came out in December last year right and that was with SGLT2 inhibitors That is the currently only mortality benefit drug in heart failure preserved ejection fraction, SGLT2 inhibitors. So there's a lot of interest in SGLT2 inhibitors now. And there is one trial that was published late last year that shows that there is a mortality benefit here. That is the only trial. Right. Okay. All right. Right. Any questions? දැන් SCQ එක ළමයි මම හිතුවේ දැන් අද මේක කතා කරන එක ලොකු තේරුමක් නැහැ because you need to write the answer to this, right? So we will do this next time with all the other MCQs and another SCQ. මොකද because you need to write answer එකක් කරලා මට එවන්න. හරි? එතකොට I will look at it, then I can discuss it better. ඒතර ඔයගොල්ලෝ ලියන ඒවල ප්‍රශ්න මොනවද? ඔක ඔක්කොමලා ලියන්නේ නැහැ මම දන්නවා. That is fantasy, right? ඔක්කොම 160 200ම ඔක ලියයි කිය, that is fantasy. But I want as much as possible ඔක වැඩි වෙලා යන්නේ නැහැ, විනාඩි 20න් ඔක ලියලා අර classroom එකට submit කරන්න. එතකොට I can go through your answer and then we can discuss in a more meaningful way. ඒතකොට කට්ටිය කරපු වැරදි හැම කතා කරන්න පුළුවන්, හොඳ දේවල් නරක දේවල්. So that is a better way of doing it. Sarangani, shall we do it like that? It's better, I think, to do it like that.
Okay, sir. Yes.
Hari? So ළමයින්ට උත්තර දාලා I think you can submit on the classroom and you answer it and just post it there නේද? Then I can see it.
Yeah, sir. We can submit.
Yeah. And then I'll have a look at a few answers and then we can discuss in a more meaningful way. Right? නැත්තම් තේරුමක් නැහැ.
Okay.
Right. So Pramodi has asked, hydrolysine ISTN, does that have mortality benefit? Yes. So from the second line drugs, people, the ISDN hydrolysine is a vasodilator, not very frequently used. But yes, that has a mortality benefit. Ivabradine has a mortality benefit. Right? From the second line drugs, those are the two ones that have a mortality benefit. Right. Okay. Any other questions from heart? So today was mostly a test session. අපි සාමාන්‍යයෙන් මේක පැය දෙකක් විතර යනවා, මම අද පැයක් විතර වගේ තමයි කරේ. We'll do more questions next time, but I just want to test if this format is okay for you and anything that needs to change කියලා බලන්න, then we can properly crack on with it after that. And we'll have to do, obviously, because we have less time for your exam, we'll have to do more sessions and more questions per session, right? But don't worry, we can finish this. Right. So the medicine part, I will cover whole thing like this. So මේකත් එකම parallel පාඩම් කරගෙන යන්න. ඒතර by the time we come to February අග වගේ වෙනකොට we'll have finished medicine. So ඒක එක subject එකක් ඉවරයිනේ. So මේකට parallel පාඩම් කරගන්න it is easier. So for next time, so Sarangani, that will be week after next, right?
So that will be on the 23rd.
Cover the
23rd, sir.
23rd. So for the 23rd, study the rest of cardiology. Especially ischemic heart disease, hypertension, valvular heart disease, and congenital so ischemic heart disease, valvular heart disease, hypertension, then a little bit on congenital heart disease, arrhythmias, mama godak වෙලාවට කරන්නේ next week, arrhythmias, ischemic heart disease and hypertension. හරි? ඒකයි අපි අර ඉතුරු MCQ ටිකයි discuss කරමු. SCQ ටික discuss කරමු. Right? So ඒ ටික බලා ගන්න. If you have time, we'll do the pericardial stuff also, valvular stuff, but depends on how much time we have. හරි?